other questions, please put in chat box.
So
I can go through some of the questions in the chat box, if that's okay.
Yeah, that'd be great. Thank you.
So there's a question about, can you talk more on sleep and Alzheimer's disease? There's been some studies with the Alzheimer mouse models lately that sleep deprivation increases risk of Alzheimer's, and there's evidence that during sleep, at least in mice anyway, sleep sort of washes out the amyloid from the brain. Whether this is occurring in humans or not, we're not quite sure yet, but we certainly recommend getting good quality and adequate sleep. This may require good sleep hygiene as far as, not sleeping too much during the day, avoiding coffee and alcohol close to bedtime and things like that. And if medications are needed for sleep, then we also recommend medications for sleep. And as I mentioned, more education is protective against Alzheimer's disease. We're not quite sure what the mechanism is here. Perhaps it gives you more of a buffer when things start to go downhill as you age. But certainly the more education you have, then the lower the risk of Alzheimer's disease. Are the blood biomarkers at the local level? Yes, we're doing some blood testing in our clinic. We're measuring A-beta levels in blood, as well as determining the ApoE type from blood. So we're definitely doing some testing of the blood biomarkers at the local level. Other blood biomarkers are available to any clinician, but unfortunately, Medicare and other insurers are not covering these tests yet. This may change in the future, but right now getting coverage for PET scans and blood tests and these other biomarkers has been difficult with Medicare and insurers. They're still in the research stage, but we think this will change in coming years, particularly as we start to get more effective therapies that are approved. If we start to make diagnoses earlier and earlier, how do we protect patients from adverse outcomes of employers, insurers, etc.? Well, if this is in the clinic, then obviously this is confidential information. You don't have to tell anyone. You don't have to tell your employer or your insurer. If it's research, it doesn't go into your medical chart at all. So, there are ways to prevent information from certainly getting to your employer or your insurer. You can also find out your own ApoE genotype from companies direct to public marketing like 23andMe will tell you your ApoE genotype. And this, of course, is entirely private between you and 23andMe. You don't have to tell anyone whatsoever about whether you have the risk gene. It's also illegal to discriminate based on genotype for medical insurance. So far, it doesn't cover other insurances like disability or long-term care. But for medical insurance, it's illegal to discriminate based on genetic information. So there are ways to keep information private from others. If you have a family history of dementia, even if you do everything listed, what are your chances of getting dementia? If you have a parent who has dementia or Alzheimer's disease, you're at least 2 to 3 times higher risk than people who do not have a parent with dementia or Alzheimer's disease. So this just reflects, some of this reflects the ApoE genotype that you inherit from your parents. But there are other genes that we still don't know yet and need to find out in more research. What age range does your research volunteers need to be? Our research, it depends on the study. Some start at age 50, some start at age 65, and sort of ranges in that area as far as the lower age limit. And then our upper age limit is usually around 85, although some studies go up to age 90. So that's kind of the age range that's typical for our clinical research and our clinical trials. Is there any research on oils other than olive oil? For some reason, olive oil always turns out to be the best, but basically any liquid oil, plant-based oil is better than any animal fat. And if liquid is better than solid and vegetable is better than animal. So there are other oils that may be just as good as olive oil, but for some reason, olive oil always turns out to be the one that's studied the most and turns out to be the best. What kind of symptomatic improvement would you hope to see in novel medicines that could be developed? So our new treatments, we hope would stop any further progression of cognitive decline, dementia, and also in dementia and Alzheimer's disease. So the people who get the placebo, we know what sort of rate of decline to expect in people who are not treated. But the goal of the new treatments is to stop this from happening. So, so it stops, stops it in the very early stage when you're still relatively functional, so you don't have any further decline. And then we go further back, and the next goal is to find people who are high risk and prevent any cognitive decline. So that's sort of the prevention studies that I talked about, is to use these biomarkers to identify people at the highest risk and then give them a treatment that would prevent them from ever getting mild cognitive impairment or dementia. So that's the goals of our treatment trials and our prevention trials. Do we know how exercise or why exercise lowers risk of dementia and Alzheimer's disease? Any particular exercise is better than other? We don't really know the mechanism yet fully, but I think part of the mechanism is that it prevents obesity and diabetes. And as I mentioned, being overweight, obese, diabetes, and then having hypertension and metabolic syndrome, all of those are risk factors for dementia and Alzheimer's disease. So one of the mechanisms may be just preventing you from getting overweight, obese, diabetic, hypertensive. But there may be more than that, and there may be growth factors that are stimulated that promote new neurons to be born in your brain, for example. So this is another area that's being investigated, including with exercising mice and other animal models of Alzheimer's disease. So we're trying to find the drug that mimics exercise so that you can just give the drug and not have to exercise. But so far, we've not discovered that yet.
That's one way to do it.
So unfortunately, you still have to exercise. And this is probably the best, the one thing that has the best evidence in preventing dementia and Alzheimer's disease. Any particular type of exercise better than the other? And the answer to this question is the one that you will do. is the best. So you find something that you enjoy doing. So whatever exercise you enjoy doing, it could be alone or it could be part of a team. So any exercise that you enjoy doing that you will continue into the future for the long term, for the long haul, and not just something that you do for a few days or a week or two. That's the exercise that is the best. And it has to be probably some combination of aerobic plus, resistance is the best combination. And the aerobic has to be vigorous enough to get your pulse elevated, to get you a little bit short of breath, maybe break a sweat. Some vigorous exercise 3 to 5 times a week, and then some resistance exercise as well. And as I mentioned, the best one is the one that you will do for the long haul. So whatever it is that you enjoy doing. And I know some people have difficulty because maybe arthritis of the knees or something. So you find something that you can do that's not painful. Some people do swimming if they have a lot of arthritis. It's not so tough on the knees, for example, compared to walking or other exercises.
Is there a way, Dr. Turner, working with Medicare CMC, so you can work with them because they are the ones who look at the aging 65 plus in healthcare and health insurance? Would it be able to work with them so you can have access to that population somehow to give the information in terms of clinical trials and what they need to do? Yeah. Unfortunately, our healthcare system just sort of, waits until you have a disease and then you get treatment, and then the health insurers reimburse for that evaluation or treatment. Not particularly strong in preventive measures, particularly when it comes to financing and reimbursing. So, our healthcare system is not really well designed to focus and reimburse for these preventive strategies.
There is another question here that came to me by accident. The question is, are there any comorbidities that would exclude one from a clinical trial?
Yes, there are. Our ideal clinical trial patient is someone who has no other diseases and takes no other medications. And of course, this person doesn't exist. So of course, our patients have other disorders and take other medications. But the things that we cannot have as part of our study, for example, a lot of our studies require MRI scans. And so if you have a pacemaker, you have metal in your body and you really shouldn't get MRI scans, or it's difficult to get an MRI scan. So people who have pacemakers, for example, are probably excluded from most or all of our research. And if a study requires a spinal tap, for example, we wouldn't want anyone on blood thinners because there may be a bleeding risk from having a spinal tap. So if you're on a blood thinner, then you would qualify for a study that has spinal tap. We do require patients to be medically stable, usually cancer-free for 5 years. And all of our studies require having what we call a study partner. So it's not just you that's signing up for a study, but someone else who knows you well.
Right.
Ideally, someone who lives with you, so that we can, we can ask questions about how you're doing at home as far as your memory and functioning. So if you don't have a study partner, then you may not qualify, for our clinical trials. But those are the big exclusions, having other disorders, other diseases, being unstable medically, having cancer in the recent past, having a pacemaker, being on anticoagulants. These are some of the reasons that you may not qualify for a clinical research study.
Okay. Amina?
There's one more question that came through, and it says, can you enroll people in trials remotely?
We're trying to do more remotely, virtually, as much as we can because of the pandemic. So we have made some components of the research remote, but obviously some of this cannot be remote, has to be done in person. And obviously things like MRI scans and PET scans and spinal taps cannot be done remotely. Blood draws can't be done remotely. But some of our treatment trials are using visiting home nurses, for example. So if you need an IV infusion of an antibody every month, some of the study would be done in the clinical research unit at the Georgetown Hospital. And but some of the monthly treatments could be administered by a visiting home nurse who takes the medication, starts the IV, infuses the medication, takes an hour or two. And so, we're trying to incorporate some virtual steps as much as we can, and trying to incorporate visiting home nurse if we can, to make the study easier to get through for people so that we can get more people joining studies.
Great.
So they usually have a lot of pre-screening, so the screening can be done remotely to see if they can, inclusion criteria.
Yeah, absolutely. Yes.
Wonderful. Well, I want to just thank you both, Dr. Hurtado